Hello everyone, this is Dr. Chris Ferrigno. Today I'll be discussing gait, which is just another word for walking. We also like to call gait or walking ambulation. So here we see in the bottom right a picture of the orthopedic building at Rush, which is where our wonderful motion analysis lab or gait lab is housed, and is also where I conduct most of my research here at Rush. We use the Motion Analysis Lab, which is full of very fancy equipment, including many cameras and in-ground force plates, to examine gait through quantifying joint motion, also called joint kinematics. So we have motion equals kinematics. And we also detect joint loads or joint forces, which is what we call joint kinetics. So I normally kind of gloss over the session objectives, but I would like to briefly go over those for this lecture. First, we will look at the general phases of gait and the subphases of gait. We're going to talk about the muscles that are active during those phases and subphases of gait. And we will also examine some of the abnormal gait presentations or gait abnormalities or gait deviations, and these include Trendelenburg gait and drop foot gait. So what is gait? So again, gait is a manner of walking or moving on foot. That's a simple definition, but why is gait so important? So it's the most functional movement we engage in, and of course gets us from point A to point B, and we're constantly exerting 1.5 to 2 times our body weight with each step we take. And over the course of a day, we take about 5,000 steps in a day, which yields about 2 million, that's 2 million steps annually. This means we load our joints a lot, and that translates into plenty of wear and, of course, plenty of injury. So why else is gait important? Well, for one reason, it's going to be on your exam, or at least a portion of this will be on your exam. Also, note that humans average anywhere from 5 to 10,000 steps a day, and that really should be a little higher, meaning that some countries exhibit more than that. The US, as we can see, is doing quite poorly in comparison to some other countries. And it's interesting to note that some of us in the US do quite well, and we see that people who are less reliant on those devices called automobiles do quite well, with the Amish men and women coming in at least roughly 15,000 steps a day. So, yes, we're not doing very well here in the US, so we're much more sedentary, and other nations are much more active. But despite that, we have similar types of injuries, specifically in our hips and our knees, due to that wear and tear. So just why should we learn about gait? Well, as you might imagine, locomotion or gait or ambulation is incredibly important. We have to get from point A to point B, and thus we are functionally independent when we're able to do so efficiently and confidently. Gait gives us an amazing amount of information about our patient and about their musculoskeletal system and their nervous system or their neuromuscular system. And when there's a problem in either of these systems or the combination of the system, we can tell a lot about their overall well-being. We can relate problems in their neuromuscular system to their gait, thus giving us a clue about what's intact and what's not intact. And as physicians, one of your biggest jobs will be to diagnose. So knowing just a little about gait and observing your patients will give you the improved ability to be able to diagnose. So what do we need to have normal walking or normal gait? Well, obviously we need some level of strength. Believe it or not, there's not much strength needed for a normal gait. However, there is a minimal threshold of strength needed. So if we don't, let's say in our lumbar extensors or our thoracic extensors, if we didn't have such strength, we might slump over. Or if we didn't have strength in our gluteal muscles, we might slump over as well. We obviously need a normal range of motion, and it's quite obvious when someone doesn't have enough knee flexion during the swing phase of gait that they have an abnormal gait. Or if they can't flex their knee, they have a stiff knee and therefore have a very inefficient gait as well. Obviously need some stability, and along with stability is coordination of movement, such we need some balance. We need some balance, and we need that neuromuscular system to be relatively intact so that we can coordinate our left and our right side, our hips and our knees and our ankles, etc. And we also need some stamina. And so if you've ever been around someone who's been bedridden for quite a while, it's hard for them to sit up, it's hard for them to stand up, and it's hard for them to take a step. So they would be looking something like this, exhausted after a step or two. So for us to walk a couple feet to a block to a mile, we need some level of stamina or endurance. So let's take a minute to look at the gait cycle, which occurs from the initial contact of one limb. So here we see the initial contact of this individual's right heel to the next initial contact of that same limb. So that right heel goes through a heel and a heel strike. It goes through a toe off, and then it goes up to another heel strike again. So that is the definition of a gait cycle, from one heel strike to the next heel strike of the same limb. So very simply, gait can be divided into two periods. We have a stance phase. So for that right limb, obviously this is in stance, this is in stance, and this is in stance. And then we have a swing phase. So in this phase right here, this limb is in swing phase until this time point right here. So we spent about 60% of our time in the stance phase with one limb and about 40% of time in the swing phase with one limb. So here we see at the very bottom the percent of the gait cycle, and this is where we get that 60%. So we get to a toe off right here. We get to a toe off at roughly 60 or 62% of the gait cycle. So let's talk about the subphases of the gait cycle here, which we see in this row. So at the very beginning, like I said before, we have what's called a heel strike. We can also call that initial contact. Okay. We have a loading response or a flat foot. So again, once you hit this heel strike, your foot rapidly goes down and becomes a flat foot, or that's called the loading response. This is where you start to exert a lot of weight down onto that limb. Okay, we're going to kind of go through the mid stance, but as you can imagine, a mid stance occurs when you are in single limb stance. So if I were to draw this person, this right foot would be on the ground and the left foot would be swinging through that way. So that's mid stance, when one leg is on the ground. So we're going to write single limb stance. Terminal stance is here where you are about to lift your toe off the ground and to enter the swing cycle. Early swing, we call this early swing or pre-swing, and then mid-swing, and then we go back into that initial contact again. So once again, basically the same information, but just a little different view for different learner. So we have a initial contact or a heel strike, okay, and we have the termination of the stance phase as toe off, and everything in between, and including the initial contact, the toe off, and then of course that mid stance when you're in single leg stance is called the stance phase of gait. Again, we're a little redundant here, but here we've again put in what's going on the other side as well. So let's further break down the swing phase of gait. So we have an initial period in this area where the limb, the raised limb, is accelerating. Okay, then we have this period of mid-swing in this area where the momentum of that accelerated limb is carried through into the final period of deceleration. So we have acceleration, and then we have momentum, and then we have some deceleration as well of the swinging leg. So let's take a couple parts of the stance phase and consider which muscles may be working primarily at those subcomponents of the stance phase. So here we have the loading response. So the loading response, again, we had heel strike, the foot came down, and now we have a flat foot, and we're about to put all of our weight down as we get toe off on the other leg. So we're going to put all of our weight down onto this right leg, okay, as we remove the weight off of the left leg. So during this loading response, what happens? I'm going to change my color here. What do you think happens? Well, the tibia needs to go forward. So I'm kind of working from a ground up approach. So for the tibia to go forward, what happens at the ankle? We need to have, just like this arrow shows, we need to have an increase in the dorsiflexion. So we need to dorsiflex here. Okay. The femur will also advance forward, right? We may get a little bit of knee flexion, but it's going to be very controlled. We'll say that if it changes at all, it's going to change very, very minor. So this is going to stay equal, okay? So we'll have a little bit of dorsiflexion. We'll have equal knee flexion extension, and we will, what will happen at the hip? As we bring this forward, our hip will, as I bring our pelvis forward, the hip will extend. So we'll be extending the hip a little bit. Okay, so here we are extending, and we're keeping this relatively constant, maybe flexing it a little bit, and then we're dorsiflexing. So let's see what muscles are acting upon these joints. So up at the hip, we are into an extension action. So what extends? Yes, that would be the gluteus maximus, any of those posterior muscles that has a moment or the ability to extend the femur. So it might also be the hamstrings, but specifically the gluteus maximus. And then also the adductor magnus. So recall that if you are in a fully flexed position, that adductor magnus gets lengthened and now has the ability to do some extension of the femur at the hip, at least to the neutral position. So from a flexed position into a neutral position. All right, what about at the knee? Well, at the knee during this phase, we need basically an isometric contraction. So we need the quadriceps to contract, and we need the hamstrings to contract. Now, during this part of the gait, the ground reaction force is posterior to the knee. So the quadriceps, as a result, is going to need to contract. Otherwise, the body would fall down. What about at the ankle? Again, we need to have some dorsiflexion at the ankle. So what dorsiflex the ankle? That's tibialis anterior. And now while that tibia is driving forward, we get that dorsiflexion. Keep in mind that there is action on the posterior side as well from the soleus to help control that action, decelerate that action. So we could really write in soleus, and I'll say light, and I'll say strong here. Okay, well, that was such a good time. Let's do another one. Now we're in terminal stance. So note that in terminal stance, the individual is raising their heel up and really wants to raise it up even higher to go put more weight onto the toes or the ball of the foot, and then also to receive weight here at the heel. So what's going to happen here? Obviously, we're going to get some plantar flexion. So we're at this angle right now at the ankle, and then we want to kind of plantar flex a little bit. We want to increase the angle here. Okay. What do we also want to do? We want to drive this knee forward, so we're going to get a little bit of knee flexion. So let's do this. We'll say flexion here. We'll get, say, plantar flexion here. And we are still we're still extending the hip, right? Our pelvis is coming forward and our femur is going backwards. So we're really effectively extending our hip. So what muscles do you think are going to be doing all these? Let's take the hip first. If you were to say that at the hip that the glute, you'd be partially right. You would be thinking right along the right. You would be thinking correctly. However, the glute's kind of shortened at that point, so we would really rely on the hamstrings at that point. But again, if you said the glute, at least you were thinking along the right line there. Okay, we need to start flexing the knee. So we would start using our hamstrings there. So our hamstrings are doing double duty towards the end of stance here. And of course, if we want to plantar flex the ankle, we would use either our gastroc soleus or both. But really during normal routine walking, we call upon our soleus more than our gastroc. If we were to walk fast or we were to try to run, we would ask that gastroc to engage. But in normal gait, we ask the soleus to do most of the work. All right, well, that covers it for the stance phase. Let's take a look at the swing phase. Here we have somebody in the initial parts of swing. So they've just had a toe off. They've just encountered toe off here, so they're bringing their leg up, and they're actually bringing it now up and forward. That's the swing leg. This is the right leg. They're swinging it forward. So you would imagine that there is possibly a little dorsiflexion, because if they didn't dorsiflex, what would happen? There's a high chance that you would drag your toe on the ground as you swung it through. So you'd probably get a little bit of dorsiflexion here at the initial swing after a bout of plantar flexion. When you think about pushing off of that leg, you've plantar flexed. So you push the foot down some, and then you're going to immediately try to dorsiflex it right after that. And as you can see here, this limb you're getting some knee flexion here. You can see that there's greater knee flexion right here as you swing the leg through. And of course, you're bringing this femur forward, so you must be flexing the hip a little bit. So let's take that hip first. What do you think is going to happen here? The hip is going to flex, so you must be using some hip flexors. What are your hip flexors? Well, you have that good old iliacus and psoas muscle. So we're going to use that iliopsoas. And then what about the knee? We said we are most likely bending the knee. However, realize that as you flex your hip, your knee is, for the most part, going to passively bend. It's going to act as a pendulum here. Okay, so most of that is from the pendulum action if you're relaxed. And if you're not, you're going to use your hamstrings. And in this case, you still might use a little bit of your hamstrings. And then, of course, down here, you're going to dorsiflex. And what is your dorsiflexor? It's your tibialis anterior. So your dorsiflexors will be working to ensure that those toes clear the ground. Okay, the last one for the swing phase. Let's get into terminal swing. So what's going on during terminal swing? Well, remember, we have been swinging this femur forward. So this femur has been coming forward. And And so we want to decelerate this femur. So we want to decelerate hip flexion. We're still flexing the hip, but most likely these anterior muscles, iliopsoas and such, are now have done their job and they're relaxed. But now we want to decelerate or eccentrically slow this hip. Also, our tibia, which was here during swing, has now progressed forward, and so we want to decelerate the tibia as well. Okay, so we want to decelerate this extension of the knee, and then we're about to hit the ground here. We haven't hit yet. I know it looks like we have, but we're just about. Remember, we're in the swing phase, so we have had our dorsiflexion of our ankle, and then it's going down this way. So we're controlling. This is a control phase. So we're controlling hip flexion. So we must be using our hip extensors for that. We're controlling knee extension. So we're using our knee flexors for that, and we're controlling this plantar flexion. So we must be using our dorsiflexors for that. So I'll circle dorsiflexors, I'll circle knee flexors, and I'll circle hip extenders, because those are the three sets of muscles we're going to be using. Sorry for my chicken scratch. So let's go to the hip. The hip extensors, what are the hip extensors? Yes, we're going back to our glute. So our glute likes to work when our hip is in some semblance of flexion, and we want to get some extension out of it. So we are eccentrically using our extensors here. What about the knee? Well, again, we're doing knee flexion. I can't read my own writing, but again, we're doing knee flexion. So that must be hamstrings. And then also we are controlling plantar flexion, so we're using our dorsiflexors eccentrically. Here it says isometrically, but that could be eccentrically as well if we're going into some plantar flexion, passive plantar flexion. Again, gravity is acting on this. Okay, so we have some eccentric activities going on in this phase. So what is happening when our foot does hit the ground? Well, obviously we have a known mass, and that mass is exerting a force into the ground. So here we see our mass exerting a force, and of course that ground gives us an equal and opposite force, minus of course the squish in the shoe or the squish in our heel, the skin or fat in our heel. And so we do get some dispersion of that force, but for the most part we have some known mass, and then we have an equal reaction force. So this slide shows you that ground reaction force in red at the different phases of the gait cycle. So here in that heel strike or initial contact, we have a ground reaction force that should actually have an arrowhead on it because it's a vector. And you can see that at least here in the sagittal plane view, and so in a side view looking at the vector in the sagittal plane, we can see that this, at the very beginning, that this vector has a relatively small amplitude. However, it acts anterior to the center of the knee joint. So it's anterior. So what is this doing? Well, this force is trying to extend the knee. So to counteract that force, our knee flexors are probably active at the very, very beginning. Well, soon thereafter, just a couple milliseconds after, you can see that the magnitude of our ground reaction force gets much greater, goes posterior to the axis of the knee joint. in the sagittal plane, and so there is a small, if you remember your moment, force times moment arm, there is a small torque causing your knee to try to flex. So we probably use our quadriceps here. Here, there's a very small moment arm. Okay, very small moment arm, so it's a smaller torque, but we're still probably slightly using our quadriceps. And then as you can see here, we can continue to do this later in the stance phase. The ground reaction force goes anterior to our knee joint. We're probably using our hamstrings at that point, and so forth and so on. With very end, we use a little bit of our quads to control this so we don't fall to the ground. If we don't use our quads here, on this one, if we don't use our quads, we fall to the ground. Here, if we don't use our quads, we probably fall, on this one, if we don't use our quads, we probably fall to the ground, although the moment is very small there. On these that have an extension moment that we use our hamstrings to counteract, this one, if we don't use our hamstrings, our knee hyperextends. So this would be hyperextension if we didn't use our hamstrings to control that. And so this slide is saying exactly that when we have these external joint torques, these are balanced by or resisted by muscle forces. Okay, just a quick assessment to see if you kind of understood what we were talking about here. Let's take this moment in time. This person is starting to put weight through their leg. They have this ground reaction force that extends up. What muscles are active? Well, it looks like it's going posterior to the axis of the knee joint. So it's going to try to bend the knee. So you're going to have your quadriceps are active here, the quads. And in this case, what's going to happen? Well, similarly, it's slightly behind the axis of the knee joint if I drew it correctly, and there would be a very small contraction of those quadriceps there to help control the knee. And conversely, we have a ground reaction force that extends up anterior to the knee joint. So this is going to try to cause hyperextension of the knee. And so we are going to use our hamstrings and our hamstrings here to balance that. So of course, many things can go wrong in this process. And so we have slips and we have trips and we have falls. And many of our presidents have exhibited these slips, trips, and falls throughout the course of history. Okay, so please bear with me as I have a little bit of a soapbox slide here where I mentioned maybe the idea that we are devolving as we go through the industrial age and our current situation in this world, where we, obviously over the last many, many years, we've kind of been in this state, and maybe we're kind of heading into this direction a little bit, maybe very, very rapidly. So does sitting, these sitting tasks, which we almost never did when we were when we were here, the sitting tasks affect us, or dramatically affect us, perhaps. So what happens with prolonged sitting? So certainly we have cultures where, like I mentioned before, that sit very, very little. We have a few of those cultures that sit very little, and they tend to be much more erect in their postures. And then we have, oh, well, this might be you or I today, maybe all day. This might be our grandfather or our great grandfather. But very few of us are sitting on the tractors nowadays. But even still, certainly had some issues because of the machinery and because of this little device right here. So we're in this position all day, and what are we doing? Well, we are. So I'm going to change my color. We are in a hip flex position. We are generally in a knee flex position, and we tend to be in a slight bit of ankle plantar flexion here, rather than in a fully extended position or maybe even hyperextended position like we see here. And then, of course, we are repetitively getting our knee straight as well, and we keep our ankle, for the most part, into a dorsiflexed position, with the exception of right here. So what does this mean? Well, we end up seeing in the clinic, we see a lot of hip flexor tightness. We see a lot of knee flexor tightness, and of course we see a lot of plantar flexor tightness. So once again, thank you for indulging me in that slide. What I'd like to do now is go over some of these gait abnormalities. Specifically, we're going to discuss Trendelenburg gait. We're going to discuss getting in and out of a chair, mostly getting out of the chair, weakness or loss of knee extension, and then also steppage gait or foot drop gait. But we'll also talk about a few other conditions as well. So here we see some common gait deviations. The first three each will have a video that follows in subsequent slides. The video links we see here are videos taken either of me or a student here at Rush, just showing, or mimicking, I should say, these gait deviations shown in each of these video links. So let's take a minute to discuss the hip musculature and its role during normal gait. Recall that when we walk, we spend quite a bit of time in single limb stance. During single limb stance, in this case on the right limb, the ground reaction force extends medial to the knee and also to the hip joint. We need muscles to counteract this weight that's being pulled over to the right-hand side. In the knee, there's very little musculature that supports the lateral knee. We have the iliotibial band that extends and inserts onto the lateral tibia. However, we rely really on the bony articulation here to stabilize the knee joint, as well as the LCL ligament. In the hip, however, since we have a ball and socket joint over here, the pelvis is naturally going to want to fall this way as a result of this single limb stance. However, we call upon our gluteus medius and our gluteus minimus to contract and to pull the pelvis down towards the greater trochanter, thus keeping the pelvis level during normal gait. If you have a weak gluteus medius, that means that this gluteus medius is insufficient or is not firing at all for whatever reason. Because of this, during single limb stance, the contralateral pelvis drops. Thus, if we were to examine the top of the pelvis, we would notice that in this case, the left side is much lower than the right. So if the gluteus medius is insufficient, We call that a Trendelenburg gait. So in this individual, on her left side, she has an insufficient gluteus medius. So the gluteus medius extending this way is not contracting sufficiently enough. Thus, she has a drop of her pelvis to the right-hand side. And as she's about to strike her right foot on the ground here, we really notice that as she starts to try to reach forward with that leg. Here's the horizontal line, and then here we have the pelvic drop with the right much lower than the left. Note that she's walking with her cane on the left-hand side. She would really help herself out if she took all of this weight that she's holding on her right side, switched it to her left, and took this cane and switched it over to the right. And then that way she would have a wider base of support. So she would have a cane support on this side, and then she would have her left leg support on this side. And then therefore she would effectively widen her base of support. Because the gluteus maximus works more in the sagittal plane, we see sagittal plane deficiencies in those with a weak or insufficient gluteus maximus. So in this image here, we show someone with a weakness in their gluteus maximus. So again, during single limb stance, in order for their gluteus maximus to not have to contract, what does a gluteus maximus do when you're standing upright? It keeps your trunk from falling forward. So we have a contraction here, and it keeps this trunk from, again, falling in that direction. If you have an absent or an insufficient gluteus max contraction, to compensate for that, if this is your hip joint, you try to create an angle that way, because you know your hip flexors could contract to keep you from falling backwards, but you don't need your gluteus maximus if you have this backwards lurch like we see in the picture here during the single limb stance. So you'll see someone, again, repetitively lurching as they prepare and go into their single limb stance, and they lurch backwards. Another common gait deviation that occurs in the lower leg is what we call a foot slap or a foot drop. So this occurs when we have a weakness in the anterior compartment of the leg, specifically or usually the tibialis anterior, but it could also be the extensor digitorum muscles. So this occurs when there is a compromise of the common fibular nerve going around the fibular head, or if there's a compromise of the sciatic nerve posteriorly, either somewhere in the posterior thigh or in the popliteal fossa, or at that split where it splits into that common fibular nerve, or more proximally either near the piriformis or in the low back. So anywhere along the path of the sciatic or common fibular nerve, any of the nerve tissue can be compromised and result in a weakness of the musculature here in the anterior compartment. So with that compromise, we have a lack of dorsiflexion. So as you swing the leg through, you're unable to dorsiflex, and therefore your toe wants to catch the ground. So to avoid that, because if you do that, then you end up tripping and falling forward. To avoid that, either you raise your pelvis up on one side, and that's called hip hiking, or you excessively flex at your hip and thus flex your knee to clear your toes from the ground. Another very common clinical scenario is a flat foot, or pes planus, pes meaning foot, planus meaning flat. So as you can see here, this individual normally should have an arch something like this, and doesn't have an arch at all. It's very flat. This is where their navicular bone should be, and it's somewhere down in here. Maybe it's even hitting the ground. So they've completely lost their medial arch. Here is a very small arch, and in this foot here, a very small arch as well. So there's a couple gait deviations that we see here. On this picture on the far right, we have a foot that has a very robust turnout, or toe out is what we call it. It's also called a foot progression angle, but we can just call it today, we can just call it toe out. So they're toeing out. You can imagine where that rotation might come from. Their kneecap is most likely pointed outwards a bit, and so we're actually getting hip external rotation in this individual on both sides during, or actually throughout, their gait cycle. So a common consequence of a flat foot is what we call a midfoot abduction, or a valgus deformity. So there we see an angle between the rear foot and the rest of the foot. So we have this abduction occurring within the foot. Another thing that we see with a fallen arch and then the midfoot valgus is a heel whip. So here on the left panel, we can see the angle of the foot, and as the person swings the right leg forward, here the right leg, now at this point we're in mid stance, and the angle is roughly the same as before. But then towards late stance, as the heel wants to come up early, most likely because there's a tight Achilles tendon or a tight gastrocsoleus complex, the heel comes up early. The heel itself drives medially. Thus we have an increase in this distance over here between the lateral malleolus and the fifth digit. So this heel drives in medially, thus the whole foot is turning out more, is effectively turning out more. And as this individual goes into late stance and into toe off, this heel will continue to drive in medially, and they end up pushing off not the tip of their big toe, they end up pushing off the inside of the big toe. So individuals with a collapsed foot will end up having large calluses on the inside of their great toe, as well as off of their first metatarsal head as well. So there's one more topic about gait I'd like to talk to you about, and that is as it relates to nerve tension, specifically the sciatic nerve. So here in this picture we have a clinician raising the patient's leg up into the air. We would call this a straight leg raise. So the clinician is assessing for some sciatic nerve tightness. So here we see the sciatic nerve coming out of the greater sciatic foramen, up the posterior leg into the popliteal fossa. At this point, it's splitting into that common fibular nerve, which is hard to appreciate. It's going laterally here. And then the tibial nerve. You can imagine that tibial nerve is going to go around the medial malleolus, which we can't see here, and down into the plantar surface of the foot. And if you recall, it splits into a medial and a lateral plantar nerve. So if the clinician decided to tension that nerve, he or she would dorsiflex the foot in this direction, and that would put some tension here on this sciatic nerve, here, and the person might perceive pain anywhere along the course of that sciatic nerve. They might even complain that it feels like a tight, very tight or painful hamstring muscle if they feel the symptom around here. So let's take this individual who has an irritation in the sciatic nerve, and we put them in a standing position. It's the same picture, obviously, but now imagine that the ground is here. So they're standing, and now all of a sudden it kind of looks like they're taking a step, right? So during gait, we know that we need some dorsiflexion. And so you can imagine that this foot is normally more dorsiflex than in the picture here. And in doing so, in taking a step, that the sciatic nerve is then therefore tensioned, or at least in a painful sciatic nerve, it might feel as if it's being tensioned and it might be painful. So in this case, if someone was dorsiflexed, they might feel pain here or here or here, and even sometimes in the calf. So if we take a real person who's walking, here obviously we have a person who's dorsiflexing a lot. But as you might imagine, if this red sciatic nerve is irritated, they'll want to dorsiflex less. So their foot might be at an angle like this when they hit. So they might actually hit with a very flat foot instead of the foot shown here. So with sciatica, with a irritated sciatic nerve, you might hit with a flat foot. And I'm not saying pes planus here. I'm just saying your foot is flat and you're not heel striking very much. So you'd have decreased. Let's cross that out. We'll say decreased heel strike. And you might shorten your step length a little bit. So you'd have a decreased step length as well. And that concludes this talk about gait. Thank you so much for your attention.